Dear colleagues, ladies and gentlemen, welcome to the View from the Thoraxcenter. This time we are previewing AHA 2023. As always, my name is Nicolas from Mieghem and I'm doing the preview together with my good friend and colleague Joost Daemen. Joost, we identified 4 trials that we wanted to highlight as late breakers.
Yeah, so a short list this time that we will review for you for the upcoming AHA, but one of the first trials that we wanted to highlight was the DAPA-MI trial. So this is a really big, typical Swedish registry-based randomized controlled trial that was presented by Stefan James. Big study will randomize 4,000 patients to Dapagliflozin or placebo in patients post-MI, so either STEMI or non-STEMI in UK and Sweden with a depressed LV function or signs of Q waves on the EKG. With a primary endpoint at 1 year of CV death or repeat hospitalization for heart failure, as you're used to for trials with DAPA, but also including, according to what we could find, other cardiometabolic outcomes, including new onset diabetes, reduction in LV function, AFib, etc. So it's not clear yet what will be presented, but clearly a very important and big study that will add to the body of evidence on the use of Dapagliflozin outside patients with diabetes. So also in this trial, no patients with diabetes. In this case, started early after ACS with the intention to improve outcome.
Yeah, this may become a very important study that definitely may affect our practice these days. And I think if one medical therapy might be an add-on to statin therapy and antiplatelets in patients after MI, it may be Dapagliflozin or an SGLT2 inhibitor if you want.
Yeah.
All right.
I have high expectations as well, so looking forward.
And it's always good to see how in Sweden they managed to use that registry for these registry-based randomized controlled trials. It is an example for other geographies, but it's very difficult to duplicate.
Absolutely.
Yeah. All right, Orbita 2.
Yeah, so Orbita 2, all of you know the trial that was a first sham-controlled randomized trial, randomizing patients to either PCI or sham with angina to either randomized to PCI or optical medical therapy alone. The trial appeared negative, but now there's the Orbita 2 trial, which is the successor of the Orbita 1. In this case, a slightly larger patient population, 440 patients to be expected to be randomized. Patients need to have stable angina, also within the, I think, most recent 2 weeks before randomization. And then patients will be randomized to either PCI or optical medical therapy alone, with the primary endpoint of angina scores at 12 weeks post-randomization. So this trial will a little bit tackle some of the hurdles of Orbita 1, meaning patients really need to have significant angina, patients need to have symptoms of ischemia. If I found the protocol or interpreted the protocol correctly. Also patients with multivessel disease are included, which at least increases the likelihood that patients will benefit from PCI as compared to sham. And the endpoint is postponed a little bit and now to 3 months post-randomization. I'm really curious to see what this trial will show us. We already know that also in ischemia, PCI actually improves quality of life. So that to me is it's not really a question that I would like to see addressed, but let's see.
Well, it's a relatively soft endpoint. At the same time, the sham control makes it, I think, attractive. At the other hand, Orbita 1 was really, in my opinion, a little bit of a disappointment. I didn't understand the trial execution. I didn't understand why you would have an endpoint at 6 weeks. And then what we did not know was that the control arm patients underwent PCI in the majority of cases after the 6 weeks. So this is a very important piece of information that hasn't received the attention that it deserved. Now we have Orbita 2. I think an interesting aspect of the study is that patients are off anti-anginal therapy when they enter the study. That is of interest, because if that is not allowed, then this study cannot be a negative study, right? This should then become a positive study. But again, the sham control makes it very interesting. Definitely it's a very important way of doing studies these days. I think also with your experience in renal denervations, sham control really is an important factor there. So let's see what's happening, and let's see how this study will be received at AHA.
Yes.
So then we move on to the ECLS-Shock trial. You're all familiar with Holger Thiele's trial that was presented at the ESC and then published in the New England Journal. In brief, the trial enrolled more than 400 patients with cardiogenic shock following acute myocardial infarction. 2/3 of the patients had a STEMI. And then it turned out that ECLS, so ECMO, did not affect outcome in these patients with cardiogenic shock. So the mortalities were still very high. There was no difference between the treatment and the control arm. But again, there were some significant limitations to the study that also affect the generalizability. I think one of the first observations that I made was, but if a patient comes in with a cardiogenic shock, an ECMO would not be the go-to mechanical circulatory support, right? If you want to help the ventricle, quote unquote, then basically you want to unload the ventricle. Well, that's not what you do with an ECMO device. Maybe that was part of the reason why we were facing a negative trial. On the other hand, I think an important contributor to the negative outcome of the study was the fact that 77% of the patients were out of hospital cardiac arrests. Well, that was also noticed by the investigators, and they are now going to present a deep dive in this concept of out of hospital cardiac arrest. How did that affect the outcome of that trial? I think it is a very important sub-study because so many patients of that trial had an out-of-hospital cardiac arrest, but at the same time, that is also the limitation of this sub-analysis, because only 100 patients out of the 420 patients that were enrolled in the study did not have an out-of-hospital cardiac arrest. So only 100 patients were not with an out-of-hospital cardiac arrest. And we're saying that these out-of-hospital cardiac arrests, they really affect outcome of patients. As a matter of fact, 1 in 4 of the patients died, quote unquote, from brain injury. So that means that this out-of-hospital cardiac arrest was basically already too much for the patient. So whatever you would do, you will never recover, bring back this patient to a normal lifestyle. So is this an interesting study? In my opinion, yes. Will we get some straight answers? I'm afraid not, because there was this imbalance.
Yeah, I agree. I think, ECPR is a hot topic worldwide, specifically in Germany, but also in the Netherlands. We observed an incredible uptake in the use of ECPR in the past couple of years, without actually a profound body of evidence supporting its use. It prolongs hospital time, it increases costs significantly, it adds burden to the hospital staff. Even last night, somebody who came in, young patient, inferior STEMI, ECPR, you need to put in a entry-grade cannula. They had difficulties in cannulating on the street. CT scan first, 3 hours delay. So the consequences of the therapy by itself are, I think, an important factor that will also drive the interpretation of these studies. So, I'm looking forward to the results that are typically well presented by Holger Thiele.
Well, but in the field of cardiogenic shock, we are all awaiting a next randomized study with another mechanical circulatory support device. So, for instance, with an Impella system where you unload the ventricle, and that might affect the outcome of cardiogenic shock in a different way. But I do hope that if that study would come around, that out-of-hospital cardiac arrest would be an exclusion criterion. All right. Maybe the last study that we wanted to highlight is a study focusing on the treatment of intermediate, high, and high-risk pulmonary embolisms. And Stefan Stortecki, your colleague from Bern back in the day, is going to present a randomized study comparing patients to treatment with either the ultrasound-assisted catheter-directed thrombolysis, the ecosystem, using the ecosystem, or the control arm is surgical pulmonary embolectomy. I think this is an interesting study, but it's maybe already outdated, because surgery for a pulmonary embolectomy I think that is a little bit a reliquary of the past. I think these days we do catheter-based embolectomies much more efficiently. It's faster, it is less invasive for the patients. And as a matter of fact, there is a randomized study ongoing, which is the Peerless trial that is comparing this mechanical thrombectomy with a catheter versus this ultrasound-assisted catheter-directed thrombolysis in patients with stable pulmonary embolisms, so pulmonary embolisms at intermediate high risk. I think if we go back to the study that Stefan Sortecki is going to present, it combines patients with intermediate risk, intermediate high, and high risk pulmonary embolism. And I think that is a limitation, that's going to be a limitation of the study, because according to the guidelines, there is no recommendation for embolectomy in patients with intermediate high risk. There is only a recommendation for the high risk pulmonary embolism. So I think that is definitely something that you have to take into account when you're going to interpret the study results. And the same thing holds for Peerless. Peerless is already going one step ahead, well, one step further. It's only focusing on the patients with intermediate high risk. And I think we first need a well-designed study comparing embolectomy with thrombolysis in patients with high-risk pulmonary embolisms. And so we won't get the answer, but I'm sure this trial will ignite some discussions there.
Absolutely. And I think to me these trials are all about patient selection, and whether you categorize them or not, I think at the end there's a lot more to that in terms of the delay, the times of pre-treatment, the operator experience. I mean, there's so much more to this than just the embolectomy or surgical or percutaneous by itself that will drive outcome in these trials. That I think the more trials we get, the better we will be able to scrutinize the findings, maybe tailor down some effects or disadvantages in specific types of patients.
But make no mistake, I'm a big believer in pulmonary thrombectomies for the treatment of patients at high risk and also at intermediate to high risk. I think we need to get better in, as you say, identifying the patients where these kind of therapies would have benefits. With that, I think we are coming to the end of this preview. Only 4 randomized studies, but I think very interesting studies that will raise quite some controversy and debate. Are you going to Philadelphia for AHA?
No, not this year.
No, I'm going to skip it too. But no worries, we will we will do a wrap up next week, and hope to see you in the wrap up as well. Thank you very much.
Thank you for watching. Bye-bye.
Bye.